how commonly do you all see Icad in Brazil or in Latin America?
When you tell me that probably it's twice more often in India than in Brazil.
So, how do you take the steps? What is the algorithm to image your patients? Can you take us through that?
Welcome to Getting Wired, Decoding Neurointervention, the podcast that takes you inside the world of cutting-edge neurovascular care. Hosted by Dr. Rajeev Sivasankar, a highly experienced interventional neuroradiologist, this series is dedicated to unraveling the techniques, innovations, and real-world challenges of neurointervention. Each episode features in-depth discussions, expert insights, and case-based learning from some of the most experienced masters in the field. From advanced procedural techniques to the latest breakthroughs, this is the go-to resource for specialists looking to refine their skills and stay ahead in the ever-evolving landscape of neurovascular intervention. Get ready to learn, explore, and master the art of neurointervention. This is Getting Wired.
Hello, friends, and welcome to another episode of Getting Wired. Today, we are very happy to welcome Dr. Bruno Parente, who is the head of Neurointervention Services at the Brazilian District Federation Hospital, Brazil. Welcome, Bruno.
Thank you. Thank you for the invitation. I'm very happy to be part of this podcast, mainly because we discuss about a very interesting content. That's something that excites me a lot, Icad. So very happy to be here.
Right. And as you all know now, the segment that we will be discussing is something which is so exciting for all of us, which is Icad. And Icad is a problem which is so common in our part of the world, Bruno. In India, especially South Asia, we see a lot of Icad. So as we get warmed up to the segment, I just wanted to get a sense of how commonly do you all see Icad in Brazil or in Latin America?
Yes, we are now maybe doing more and more diagnosis of ICAD because in the last years here in Brazil, the access for the poor population for the CT scans became easier, and now we are seeing a lot of cases. We are seeing a lot of cases in the acute stroke phase. We are seeing a lot of cases for elective case from patients that show symptoms that oscillate a little bit. But now I can tell you, probably we are chasing 20% of our stroke case with ICADs. We are seeing probably more and more cases in our offices of elective ICAD case.
Right. That's so interesting that you also see about 20% out here. In fact, like we were chatting last night, we have almost 40 to 50% of our underlying acute ischemic strokes. Studies have shown ICAD could be the culprit in South Asia, East Asia, Central Asia, China, etc. So why do you think that ICAD is so prevalent in some parts of the world and not in the others? Any thoughts on that?
Yeah, it's very interesting to hear this number from you, Rajiv, because you have a population that's 6 times our population. You have 1.5 billion in your country. You have here in Brazil 250 million. When you tell me that probably it's twice more often in India than in Brazil, I can calculate in my mind how many cases we can treat in India if we go further with the diagnosis. I think that we have 3 pillars to justify why it's more frequent in Asia, in China, in India, then in South America. Probably the first one and the most important is the genetics of the population. Uh, we know that for Asian genetics, sometimes the histology of the vessel wall is a kind different, it's a kind more fragile than the histology of the black people from Africa that is very prevalent here in Brazil. When we talk about the European population and the white race, that's very prevalent here as well. So probably we have a media layer in adventitia layer a little bit thinner. It's not bad at all. So sometimes it's something that is good for the evolution of the whole life for the flow, but maybe it has something to do with the prevalence of Icad. The second pillar, in my opinion, is the primary medical assistance for the population. Prevention of hypertension, prevention of diabetes, prevention of dyslipidemia. And we share this problem. We know that we have a huge population. We are not a country that's very rich, even if we can offer for part of our population a good assistance, not for the whole population. So sometimes we have patients that has more than 20 years of hypertension, diabetes. And the third pillar probably is the access that the population has to the high specialty hospitals, because sometimes they take years to get access to the specialized medicine and treat the disease. I think that these three pillars maybe give us the reason, and maybe we have reasons that we don't know so far.
Right. A very interesting perspective and thoughts, but I think a lot of us share the same thoughts. In India, diabetes is very prevalent, along with some parts of India having dyslipidemia prevalent, like in the southernmost parts of India, where triglycerides are very high, and all this can lead to a very aggressive ICAD. So, given the fact that it is a global problem and with so much of cross-border immigration and work-related travel, uh, every part of the world will be seeing ICAD now in equal kind of proportion in a few years from now. And I think that insofar we haven't given enough justice to this disease, the kind of respect it deserves. So let's kind of hear your thoughts on uh, what is your kind of imaging protocol for patients who, say, come with a stroke, a small stroke, and are detected to have a stenosis in the supraclinoid ICA or the petrous segment or the basilar. So, how do you take the steps? What is the algorithm to image your patients? Can you take us through that?
We always try to do a CTA, a CT angiography. We know that is maybe the most precise image for calculate the grade of stenosis. Less artifacts and show us about what's the real lumen that you have for that diseased vessel. And we always try to do angiography using MRI, mainly through the vessel wall study, to know about the integrity of the plate. For us, it's very important to decide about the treatment. Is the plate stable or unstable? And with the MRI, we can tell about intraplate hemorrhage. We can tell about regularities of the plate, necros, focus inside the its structure of the plate. But for us, these are just the diagnostic methods that starts the investigation. The main image for us will be always the DSA, the angiography, because there we can know about the anterograde flow and the retrograde flow. And for us, sometimes for the case that started with just a TIA event without a main stroke, a big stroke lesion, we try to analyze if there's a balance between the anterograde flow that's reduced because of the plate and the retrograde flow that evolved after the necessity of the leg flow. We try to calculate this balance to know if it's stable or not. And sometimes when we see that it's unstable and the patient has a recurrence of the symptoms, we go for the treatment. If it's stable and if the patient reacts for the clinical treatment without any recurrence, we keep the medicines to the clinical treatment.
Very.
I don't know if
So,
you use the same protocol or something different.
It's about the same, I guess, because we do the initial stroke imaging using either CT scans or MRIs. But I think what you mentioned was very important, to use a high quality 3 Tesla or more vessel wall imaging to help us gauge what kind of plaque we are dealing with. Is it a soft plaque? Does the plaque have any features of instability? To help us decide. So, while on this topic, what are your thoughts on, we know that the intracranial vessels are not extracranial vessels. They're not the same as peripheral arteries or coronaries. So, but there is a lot of transitional zone in this. So, what are your thoughts on positive remodeling of these vessels? Because, like we know, positive remodeling for those who are little in training or junior fellows, these are conditions in which the plaque allows the arteries to enlarge in lumen. So the lumen on a DSA may look normal, but the vessel wall is actually got a lot of plaque, and that is a cause of recurrent embolic strokes. So positive remodeling is a cause of recurrent embolic strokes, which is lesser known amongst neurointerventionists. So, what are your thoughts on that?
Yeah, for sure, for sure. I normally say that it's like a puzzle that you have to put piece by piece to take your decision about treatment. I think that this remodeling of the vessel show us that probably the vessel is struggling to keep the right amount of flow to that brain area that depends on it. Sometimes you can see proximal remodeling, sometimes you can see distal remodeling, sometimes you can see the topographic remodeling of the wall of the vessel, not of the lumen itself. And it shows, in my opinion, the instability of the lesion. Because as long as you know that the lesion is progressive, and probably it will modify the flow a little bit stronger than now in the future. And you know that the vessel is almost on the limit of the adaptation to this flow modification. I tend to put one more mark in my decision to treat, my decision to make the intervention of this case.
Right. And, as we go up distally to the smaller, truly intracranial vessels, it gets more and more negative remodeling becomes the dominant feature because there is a very thin tunica media, very thin tunica adventitia. So the scope for positive remodeling reduces, as we know, which is why it gets narrower and narrower. And we don't see the positive effects like we see in the petricized CA or the cavernous, which bulge out more with disease. Right, I agree with that. So, uh, what is your kind of management algorithm when you see a patient with say a first time stroke has got a high grade supracoroidal ICS stenosis, which is not 95% but say 60 to 70%? uh, do you hike up your statins? Do you like to do dual antiplatelets first and then add oral anticoagulation? Do you wait for to add anticoagulation after a couple of months? So how do you go about it?
Yes. We are now in 2026, but we are based on data collected in the last decade, 2014, 2013. The main trials that talk about Icad complication rates are based on the techniques and the device used at that time. And obviously, they are not good. Obviously, they talk about 20, 25 percent of complication. That's unacceptable for an elective treatment. And we have to keep this in mind because in the end of the day, if we have a complication, we have to show what the literature talks about. And if we take the risk and the risk happens, we are in a bad situation. So for now, if I see a patient that had a stroke with Icad lesion, even if I know in my sense that it has to do with the stroke and probably it will increase the risk of a recurrence, I try to optimize all the clinical base of my patient. I will try obviously to stabilize the arterial tension, to stabilize the LDL under 70. That's an aggressive adjustment, but I try to do this. Obviously, try to stabilize the glucose of the patient. In some cases, I know that it won't be enough. I know this, but I have to wait and see if the patients will have any recurrence that allow me to do the treatment. Sometimes I'm in doubt if the Icad was really the reason of that stroke. We know that sometimes it's just a point of confusion. The origin of the etiology of the stroke is sometimes cardiac, sometimes out of the Icad lesion. I'm more comfortable to wait. Sometimes when I know that the Icad caused the stroke, I go for the clinical treatment, but as long as the patient has any TIA or any recurrence, I go for the treatment.
So, which means that no, these obviously there's no right or wrong, black or white answer for these, but in case a person is on dual antiplatelets, appropriate management of his diabetes, blood pressure, has lipid lowering agents on board, and has say another TIA, what is your say cutoff to offer them stenting? Do you look at a percentage? Do you say 50%? Do you say 60%? How do you offer this treatment? When do you offer it? Or do you look at the vessel wall imaging, look at the risk factors of the plaque, and then offer them treatment?
Yeah. I analyze first the recurrence, because the patient had even a TIA after the optimization of the clinical base. I attempt to treat. I look at the grade of stenosis. Obviously, we don't have something so specific like we had for this transcranial stenosis, that we know that more than 50% with symptoms, or more than 70%, even without symptoms, we are allowed to treat. But I try to be to have a tendency to treat over 50% of stenosis. I look at the anterograde and retrograde flow in the DSA to see if it's balanced or not. And I try to look at the vessel wall analysis to see if the plaque's stable or stable. If I see any irregularity in necrosis, any intracranial hemorrhage, I increase my
Intraplaque hemorrhage.
Intraplaque hemorrhage.
Yeah. Intraplaque. Yeah.
So these four aspects together makes my decision, and I discuss with the family. Tell them that we don't know exactly what's the rate of complication, but we have to consider that we will have probably 20% of chance of complication. But put the four aspects together. It's always something that's not so precise, but I try to do like this. And you, Rajeev?
And I think you and I both agree, and so do a lot of our friends who do a lot of Icad work, that the Sampras and the visit studies are completely wrong. I'm going to use a strong word, are completely wrong when they talk about the complication rates of Icad stenting, at least compared to the kind of data that we all have. And don't you think it's time to revisit this kind of disease segment and Icad stenting, and look at it with fresh perspective? Because we hardly have, maybe less than 2% complication rates, because our understanding of the disease and the kind of techniques that we use, and with the latest hardware, it's become a much safer segment to treat. Don't you agree?
Yeah. I think that we have now a knowledge about the Icad disease that's better than before. I think that we have now better support catheters to give us a more precise manipulation of the diseased part of the vessel. We have now better device. We need to manipulate a little bit less the lesion than before. We have best medicines comparing clopidogrel, that was the only option that we had before, and now the prasugrel and ticagrelor. So, in my opinion, we need to do a new collection of data to probably propose a trial as or more robust than Sampras to show that the rate of complication is not that high. I completely agree with you. My center will normally face 3 to 5% of ischemic complications. It's much lower than we saw in the literature. I'm glad to hear from you that you have the same experience.
Yes, absolutely. So since we are on the topic, can you run us through your principles of how you choose your hardware? What is your typical access like? Say, let us take an example of a tight supraclinoid ICA lesion, what would be your axis? And I shall give you a typical scenario. You feel free to illustrate the case if you have an example to share your screen with, and you can take us through your steps.
Yes, yes. First, I would like to show a slide that show our ideas. What would be the best device, the ideal device to treat Icad? Let me try to. Probably what we need when we try to treat an Icad plaque. We need to reduce the number of maneuvers. We need to reduce the manipulation of the plaque. So I think that for this purpose, a balloon mounted stent's always the best solution. I think that you pass through the lesion the device that will fit the stenosis, and you have the balloon with this device. You don't need to manipulate it twice. Easy to navigate because we know that the balloon mounted stent most of the times is more rigid and difficult to pass through the curves. So modify the structure of the device, of the stent, and the balloon itself to make it more flexible as it could be for a single microcatheter. It's the goal. Gentle to the plate, it means very, very thin in the nose of the device, not to make friction against the plate when it passes through it, with always using a semi-compliant balloon. Because, in my opinion, and what I saw is that after we reduce it, the demand for pressure to inflate the balloon and to open the stent will reduce it a lot. There is no plow effect, the fracture of the plate, and the ischemic complication. Even for perforators, even for distal microembolization. And to has a very, very accurate control of the balloon inflation when we are trying to fix the plate. And obviously, we need to use a fast exchange balloon. But as long as we increase the length of the device that has a micro guide wire passing through, we increase the stability of the device itself. So probably these are the main facts that will reduce. There is no plow effect. That's the spread of plate that we do after pushing the plate against the vessel wall, and that can close the perforators like we see in this picture. And you can reduce the microembolization that we can see here when we fracture the lesion, and we create this space of micro debris that can increase the rate of ischemic complications. I think that this ideal new device with the new techniques, with the new support intermediate catheters, will allow us to work with a rate of complication lower than 5.
Right. So that is your ideal device, but we still don't have a dedicated neuro balloon-mounted stent for Icad in India as yet, and we will hear about you because for my viewers, Bruno does have a device which is balloon-mounted and which has some of the properties that he mentioned. So we'll hear and learn more about that during the segment. So let's go through, say, some of your cases. Let's see your setup. Do you go in with a triaxial setup, and what is your choice of your intermediate catheter, do you do a submaximal angioplasty first, or do you straight away go with the balloon mounted stent that you have? Because we don't have that in India, and I'll tell you later what most operators in India do.
So let me show you another slide with ideas about the technique to treat, and we can discuss a little bit about the setup to do this. These are the ideas that we use in our practice. We always try to do a suboptimal angioplasty. We know that if we double the lumen, the functional lumen of the vessel, we multiply for 4 the amount of flow that we can have. So if we have 1 millimeter functional lumen and we goes for a 2 millimeter functional lumen, we will multiply 4 times the flow for that brain area, and it's enough. So we always try to target in 2/3 of the normal lumen, the proximal normal lumen of the vessel. We always try to avoid very angulated vessel topography. If we have a lesion in an area that is more than 30 degrees in angulation, we think more about primary angioplasty with balloon rather than the treatment with stents. We try to use a distal navigation catheter as close as we can to the lesion. I will show you a case that was very challenging and that helped us a lot because it gives us more stability. So we try to use a 5 French distal intermediate catheter like Sophia or Utrecht or Navian. We try to navigate our micro guide wire as far as it's possible. For example, for a lesion, any one lesion, we try to go with our micro guide wire in the M3, in the distal M2, because it straightens the lumen inside the plate, and it makes our device navigation more stable. And we always try to use a stent that's at least the double, has the double of the length comparing to the lesion, because we have to cover at least 50% of the length proximally and 50% of the lesion distally. We try to control the inflation of the balloon. We try to do it very, very slowly and with the minimum pressure needed to open the balloon. And we always try to aspirate before deflate the balloon to try to recover the micro debris. We always use ticagrelor and prasugrel instead of clopidogrel. We know that it's better for the efficiency of the dual antiplatelet therapy and the idea of the new device that we told. When we see this case, for example, that we had a very distal Icad disease, a challenging Icad disease between the M2 and the M3. We had a very turtles, cavernous, and a supraclinoidal ICA segment. It would be very challenging to pass balloon-mounted stent in this kind of lesion. We tried to navigate our intermediate catheter as far as we could, close to the lesion, because it decreased the angulation of the ICA supraclinoidal segment, make the navigation a little bit easier for us. Here we see the lesion was very huge and undulated. We tried to pass the 14 microguide wire and navigated very far. We know that during this, we straight a little bit the lesion and we we create the environment to make the navigation of the device less aggressive. And here we can see how we could place a balloon mounted stent with 6 ATM. I just mentioned here that for coronary balloon mounted stents, normally we need more than 12 ATM pressure because they use a non-compliant balloon. So that's the advantage of using a semi-compliant balloon to treat this kind of lesion. You can see after and before. And just to introduce these concepts, these technical concepts and device setup, I think that these kind of modifications regarding what was done in 2014 probably is the main reason to have now a complication rates that's lower than before.
Right. Oh, that's a nice case. But I want to know something. How navigable is Apollo? Because you showed us a case using the Apollo stent system. We don't have that here in India. I think it's in stages of approval, last stages of approval. But that was a pretty distal M2, M3 junction Icad. And that means this device must be quite navigable and easy to get up so distally.
Yes. Let me show you maybe some pictures that will help me to answer this question. Just a moment.
And the Apollo is a rapid exchange system or
Yes.
over the wire system?
Yes,
It's rapid exchange.
It's a fast exchange system. It looks like a coronary stent in terms of design. We can see here some difference. Probably here is the main difference between them, the balloon they use. We see that the coronary stent, we here in Brazil, we use mainly the Onyx Resolute. We see that it demands a pressure of 12 for the opening of the stents. When we talk about the Apollo or Servia, I think that's the name that they will use in India, the nominal pressure decreased to 6. And for me, you treat the lesion more gently. When you do this, you reduce the risk of fracture and micro debris production in this case. We see here something that's very useful. Because we use a semi-compliant balloon, if we overinflate the balloon, we can increase the diameter of the stent in more than 10%. So sometimes we can play with this using a smaller diameter, but knowing that we will increase a little bit the pressure to decrease the gaps after and before the lesion. So the stent will adapt with a smaller diameter through the lesion, but will be a little bit larger in diameter before and after, making it more stable. Something that you can't get with the coronary stent. And here, something that, in my opinion, helped me a lot in some cases. The design of the noose is thinner and it's like a needle. It's progressive. So it's easier to pass through the irregularities of the plate. When we see the nose of the coronary stent, it's rounded and sometimes more rigid. So you have it stuck against the plate, and when you force it through the plate, you can produce micro debris. That's another point that help us in terms of navigation. And another point that for me is very useful when you use a semi-compliant balloon. That's why I asked them to even produce a softer balloon for the next version of Apollo, is the dog bone effect. Because when you start to inflate the device, you have the opening of the balloon distally and proximally to the lesion, but the stent does not start to open before it gets the blockage of the flow, the blockage of the distant proximal flow. So when you inflate it very gently and slowly, even if you fracture the plate, the micro debris won't go forward, won't go distal, and won't produce micro embolization. And if before you deflate the balloon, you apply a negative pressure, you can aspirate the micro debris instead of allow it to go further. So these modifications, in my opinion, they give us a device that's more for the intracranial vessels than for the coronary vessels. We have to keep in mind the histological difference between the layers of our intracranial vessel and the coronary vessel. The coronary vessel has a very, very thick muscular and medial layer. So it can support sometimes that pressure that we talked, 12, 14, 16, 20 ATMs. And the plate normally is harder out of the brain than in the intracranial vessels. So these modifications in the design, they make me very excited with this device.
That is very interesting. So, is this a cobalt nitinol stent or cobalt chromium stent or nickel titanium alloy? What does this stent have? Or platinum stainless steel? What is it?
No, this is stainless steel. Stainless steel stent.
Is it stainless steel?
Yes, because
Right. So does it make it very rigid and straighten the vessel over a curve? Because my question is, sometimes the stenosis is on the curve. Say a cavernous bend, or so. How does it take the curves? Because stainless steel isn't known to be very compliant and does not, behave like a braided stent.
Let me show you something that attracted my attention. When we talk about the difference in histology that I told, this is the picture that shows us how different is the coronary and the intracranial vessel. And we just try to find.
In fact, while you're hunting for your slide, I think we should propose to change the name of this from intracranial stenting to intracranial scaffolding, because we don't need a stent, you need a scaffold. And that's the primary difference because of the histology. You're so right.
I truly believe. I will try to find the picture that show the multi-link design of this stent and how it worked for me in a very angulated vessel that I treated. So here it is. Let me share this screen. Look here. the difference for this stent, even if it's a stainless steel stent, they could take advantage of the opened cells and put these multi-links between the segments of the stent. That's why it can adapt to the curve instead of modifying the curve or straightening the curve. So here we can see a case that we treated in the Petros segment. I can show you the case from the first pictures, but here is more to show how this stent can get a 90-degree angulation without straightening the vessel. It's not as flexible as a self-expandable stent, and it's hard to get it. Obviously, the conceptions are different between the balloon mounted and the self-expandable one, but it can give us conformability that's higher comparing to what we had before in terms of coronary stent. Here, just to show you the case, it was a patient that was suffering with the absence or the decrease of flow, a very huge lesion in the Petros segment, more than 90 degrees in angulation. Here you can see how it's important to have the intermediate catheter close to the lesion, how it allows us to gently negotiate with the plate to pass through, and how important to control the pressure that we will use to open the device. You can see here it opens first in the extremes to break the plate right after. And here the result that I showed. So I think that we don't have the ideal device so far, but we at least have a better device, and we have a way to do. We have plans to probably improve this design to have a flexible, very easy to navigate stance for the future.
So, the next important piece of information that I'd like to share with everyone is that there are two schools of thought now in the manufacturing of devices tailored towards Icad. So one school you have just demonstrated uses semi-compliant balloons on a very navigable multi-link system. The other school which is developing these devices does away with the balloon completely and is using the technology of only using self-expanding stents, especially in perforator-rich areas like the M1 or the basilar. So there is no snow plowing effect. There is no carinal effect, which means that sometimes there is a functional compromise to the perforators. So despite the perforator not getting physically impeded by the plaque getting pushed into the perforators, there is a modification of the flow by the presence of the stent across it, which prevents the flow from going into the perforators. So this segment of device manufacturing is developing a generation of devices in which there is more radial force, or rather more chronic outward force is the right term, to the middle part of the stent and a little lesser towards the distal parts where it just requires a safe anchor. So if you have to kind of choose between these two segments of devices, what are your thoughts of use of angioplasty in perforator-rich areas? Because we see a lot of M1 disease where striates originate, or mid-baselars where the midbrain and pontine perforators originate. So what should be the choice of hardware in your opinion? Should we do a submaximal angioplasty and then put a self-expanding stent? Or would you still feel that committing to a balloon mounted stent would be appropriate?
Yes, I think that the advantage of the self-expandable system is flexibility and less radial force against the plaque. They are trying to adapt, like you said, to a specific part of the stent to apply a higher radial force, and for the extremes of the stent to apply a less lower radial force. So if you are facing a soft plaque in the middle of the perforators of the basilar artery or any one segment, I think this will be the best indication for this system. If you are facing very hard, a harder plaque in topography that you don't have to keep in mind the risk of the perforators as high as in these segments, probably the balloon mounted stent will be the best option because we'll manipulate a little bit less and you will have a more effective applying of the radial force. I think it probably give us the knowledge about what kind of topography and what kind of plate would be better for each option of stents.
Right. And the coming to the a few case scenarios. So if it's okay with you, what I'm going to do is that I'm going to show you a few typical cases that we encounter in our day-to-day practice, just to see your thoughts on that. So I'm going to share my screen, and then you'll get an idea of what we do, because we don't have the Apollo. So let me just see if I can share the screen.
Just to let you know, Rajeev, we don't have the Credo system, the self-expandable balloon with the double Lumi semi-compliant balloon. That's the Neurospeeds. We don't have it so far in Brazil. So what we do in this case that you told me that I'm not so confident with the balloon mounted stent, we go for the primary angioplasty with drug-coated balloon, drug-eluted balloon. So,
and what is your experience with the long-term patency and restenosis rates with the drug-eluting balloons?
Yes, we can see it probably in a higher rate comparing to the case that we stented. I tell you, we did not do probably more than 2 alternate cases using the primary angioplasty. We collected data of 2 recurrences, not more than this, but we need more time and need more experience. We need to share the data with our colleagues in India because you are very experienced in using the CRIDI system. We are very experienced in using the balloon mounted stent. I think it will be very useful to share the experience.
Yes. So, just to know your thoughts. So this was a 57-year-old man. He was a never smoker, and his usual comorbidities of diabetes and hypertension. He had come with one small posterior circulation stroke a week ago. There was no support from the posterior communicating arteries, and he had this.
Just to let you know, I think the screen is not
You're not able to see this? Okay, just a moment. All right. So uh, this was a case which I was talking about, a small posterior circulation stroke in a diabetic and hypertensive. This is just distal and incorporating the Icas, which are big on both the sides. And it extends from the proximal to the middle thirds of the basilar artery with some poor distal flow. He had another recurrence. So in your center, in your setup, you would still go ahead with a balloon mounted system?
No. For this case, probably no. It would be very interesting to see the vessel wall study to know about the instability of the plate. But from the first sight, I tell you that probably I would use just the primary angioplasty for this case.
All right. And I understand you all don't have the credo. So, like you said, we went ahead and we used the neuro speed and the credo system. I wonder if I have that image. So this was the stent that we placed across. I was expecting to lose the ICAs because of the snow plowing effect, but like you had said early on, that submaximal angioplasty is the rule. So this is what we did, and of course, a lot of improvement in the circulation and the system and the symptoms in it. So, which brings me to the point of what are your thoughts on if you compare the three parameters: radial force, radial resistive force, and chronic outward force between all the stents that we have with us? We have the Atlas, the Neuroform Atlas, we have the Credo, we have the Elvis Evo, the Leos, and you have the coronary stents, and now you have the Apollos. So, if you have, or if an operator has the choice of all this hardware in front of him, do you think that there is a rationale or a scientific basis in choosing hardware?
Yes, yes. For in my opinion, if you risk to spread the plague against the neighbor perforators, you should go to the stents that are more adaptable for the regularity of the plague, because they won't force the plague itself against the vessel wall, but they will conformate against the regularity of the diseased lumen. So for this case, I would propose exactly what you did, the self-expandable stent. I think that if I'm not wrong, the Aquino, that's the same stent as Credo. HRF is the one as the self-expandable stent with the higher radial force and the resistance. So it would be the solution, in my opinion, for this case or for a case similar in the NU1, similar case in the NU1. But for example, for an N2 lesion, that probably the inflation of the balloon would be less precise using a sun-compliant balloon without a layer of metal, making that energy of the inflation of the balloon more homogeneous against the tiny vessel wall. I think that and you don't have to be so concerned about the perforators in that topography. I think that the balloon mounted stent, a small balloon mounted stent, would be safer. And when you have to face a very hard plate in a structure like the petrous, the cavernous, or a more proximal lesion, the balloon mounted stamp will be more suitable as well because you can apply the pressure more homogeneously, and you know that you will modify the plate more precisely rather than using a semi-compliant balloon and a self-expandable stent. I don't know
And
if I
what
was
was
very clear about my
no, no,
position,
you
but
were,
yeah.
no, absolutely, because you're right, and that is such an important concept because histologically, as we move proximally away from the truly intracranial vessels, the media starts getting thicker and the external elastic lamina starts appearing patchily histologically, which is why the plaque gets harder. The remodeling is different from truly intracranial vessels. And like you correctly said, using a balloon mounted stent makes a lot of sense proximally. But as we go distally, there's so many more curves. It's so much more fragile, the vessels, that we got to be careful. Like I'll show you another case. I'll just share this again. This particular lady had recurrent strokes. So again, emphasizing your principle of keeping the intermediate catheter very high up. And you can see a very tight siphon here. Again, I was very intrigued and impressed by the nose cone of the Apollo because the Neurospeed balloon wouldn't take this. I was unable to get the balloon across. So all that I could get across was a headway duo. So out here, I just did what I call bareback stenting. Now, there's another thing that I see a lot in Indians. I don't know of other parts of the world. There's a lot of calcium in our Icads, which makes these lesions extremely tight. So I did the bareback stenting here, put a credo across, got the lumen open, and this was the follow-up 1-year control. You can see the calcium here. The stent is opened up over a period of a year and pushed the calcium out. So that's a kind of advantage of these self-expanding stents that they would go through even a headway duo. And because we don't have experience with the Apollo, I'm waiting for that. This is something I wanted to ask you, that do you all see a lot of calcifications in your ICADs too?
Yes. Sometimes it demands a predilation of the vessel. Normally, when I try to pass the Apollo and I can't because it stuck, I try with a 2 millimeter balloon, and sometimes I use some specific maneuvers like try to pass a 4.2 French catheter, like Phenom Plus or Fargo Mini, with 3 millimeter coronary balloon, half of the balloon out of the catheter, half of the balloon inside the catheter. So I try to inflate a little bit the external part of the balloon against the plate, and I pass the 4.2 French catheter through the plate. And after I pass this Apollo inside this catheter, and I retrieve, I pull back the catheter, and I have my stance in the right position. That's what I do. Congrats for the case because it was very challenging. But did you predilate the lesion before?
So I tried to take a 1.5 millimeter balloon across, but I couldn't get the balloon across at all.
Wow. So the stent itself could
Yes.
expand the. Good. Every case is different.
It's different, exactly.
Yes, yes.
So which brings me back to the to another case where I wanted to know your opinion. All right, so this was similar to yours. This was just a petricized CA, And just to show you this is how we see the stenosis. But that's not important because out here, it was something very similar to what you showed, and you can use any balloon mounted stent and it works very well. So this is what I wanted to speak to you about. You showed us an M2, M3 lesion. So I'm showing you a lady who had recurrent ACA territory strokes, and this is a segment we don't speak about often. A lot of hypoperfusion here, and what you call retrograde flow is probably what we are analyzing here as a collateral support to that area. And this was a very tight A2 A3 junction ACA. You can see it out here with a trifurcation at the pericallosal, frontal, and callosomarginal, and hypoperfusion there. So across this curve is something that, and quite distal, it's very difficult to get a device across here. A challenging anatomy across the across the A1, A2 junction too. So of course, I'll just show you what we did was place a braided stent here. So the question I had for you, and this was a result, the hypoperfusion before, and now you can see immediately after she did very well. She's like a year and a half plus the stenting. So the question I have for you is that, do you think there is a role for using more and more braided stents distally in our Icad, and should we be looking at it also more aggressively in our stroke management? Can you uh, once again
Much
repeat
better.
your comments on your thoughts of the use of braided stents in very distal ICAD across bends, especially?
Yeah. If you can have a support close to the lesion, like we showed in that case of the MCA lesion, I think the balloon mounted
Yes.
stent is suitable. So
Right.
what I keep in mind when I decide if I will use or not the balloon mounted stent, if I can navigate a 4.2 French or a 5 French intermediate catheter, if the anatomy allow me to navigate the support close to the lesion, if it allows me, I feel very confident to use. If I know that I have to cross the ACA or the A2, A1 transition, and if it's very undulated, I go for the balloon angioplasty alone, or I do the balloon angioplasty, and after I use a self-expanded base stent like you did.
Okay, great tip. So a few rapid questions, rapid fire questions for you. Uh, do you think drug-coated balloons are going to be the next frontier?
Yes, I think they are part of our weapons, of our tools. Sometimes if you have a very, very tiny vessel, but important, eloquent vessel that you need to improve the lung, to weaken stenosis. In my opinion, it's a good option sometimes. I use it more and more.
Yeah, we would like to see maybe the next time more cases of that, because that's something we don't do very commonly out here. And uh, what is your advice to someone who's starting off their ICAD journey, a younger colleague? What is the one mistake that you've seen, say, younger people make?
Yeah, probably the first one is don't mind to aesthetics. I think that trying to be functional and sometimes improve a little bit the looming, but not perfectly, not getting the same looming as we have proximal to the plate is the goal. Our tendency is always to try to do the best. And sometimes you think that doing the best is during the larger angioplasty that we could, but it increased the risk of complications. And another point is mind the support. Mind the support because when you are very stable in your navigation, you are more gentle to the lesion and you reduce the risk of complications as well.
Great practical tips, both of them. And what is, do you think we're entering the era of post-Sampras, post-visit trials? Don't you think that we should be working towards entering a world? Because, a lot of our colleagues are very guideline based. And unfortunately, like you mentioned earlier in the segment, the guidelines are based on 2010 and 2013-14 data, which isn't right in today's world. So I sincerely think that there should be a collaboration or a collaborative move to the current era. What do you say?
I think we need to think about a robust trial to show what's the tendency today with these new techniques, these new advice, these new ideas. We had an evolution of the Icad treatment. We now have to prove which are the rates of complication, the data using these new concepts. I think that, like I said, we here in Brazil, in India, we have a population that's not the same, but share a lot of similarities. And it will be probably the goal for the future to publish this.
Right, I agree. And one of my final questions, where do you see AI helping us in ICAD management? Do you see a role for AI?
Yes, I think that AI will allow us probably to take the best decisions sometimes. Like I said, you having in one extremity the larger angioplasty that you could do. In the another extreme, the smallest angioplasty that you could do to make an improvement for the patient. Otherwise, you increase the risk of thrombosis of the stent because you have metal with a slow flow. So I think that the AI will probably help us to predict what would be the best option, size, length, to treat Icad lesions. We are looking forward to it.
Right. So, Bruno, this was a fantastic segment, and you have given us lots of interesting thoughts about the new devices which you have been using, your experiences, your advice to get better results. Thank you from the entire team of Getting Wired, and I hope to see you soon at one of our meetings. Thank you so much.
It was a very, very interesting discussion about the topic. Very glad to share the experience with you, and very happy to be part of your podcast. Feel free to invite more. It's a pleasure for me.
Absolutely, we'll do that. So see you soon, Bruno. All the best. Cheers.
Cheers. Bye. See you.
That's a wrap on today's episode. If you enjoyed this conversation, don't forget to like, comment, and share. And for more insightful discussions, make sure to subscribe the channel.